Welcome to Medics in Minutes, where we simplify complex medical topics into clear, easy-to-understand lessons. Today, we'll be focusing on hemorrhoids, a common yet often misunderstood condition. In just a few minutes, we'll walk through the anatomy, pathology, risk factors, diagnosis, management, and finally, how to prevent them. Let's get started. To truly understand hemorrhoids, let's look at the anatomy. Hemorrhoids are actually dilated anal cushions, which are made up of hemorrhoidal venous plexuses. These cushions are highly vascular, meaning they contain a rich blood supply. Now, an important landmark in the anal canal is the pectinate line. Hemorrhoids that occur above this line are called internal hemorrhoids, while those that form below the pectinate line are called external hemorrhoids. This distinction is crucial, because it explains differences in symptoms, pain sensitivity, and management. Now here's something interesting. Internal hemorrhoids tend to appear in very specific locations, classically at the 3, 7, and 11 o'clock positions when viewed in the lithotomy position. This detail is not only important for diagnosis but also helps surgeons and clinicians during treatment. Now let's break down the underlying pathology of hemorrhoids. The central problem is persistently elevated venous pressure in the hemorrhoidal plexus. This increased pressure causes the venous cushions to become dilated and engorged. The most common triggers are chronic constipation and repeated straining during bowel movements. Over time, this constant pressure stretches and weakens the supporting tissues, leading to symptomatic hemorrhoids. Who's more likely to develop hemorrhoids? Several risk factors have been identified. Pregnancy is a key factor, because hormonal changes and increased abdominal pressure both contribute. Obesity adds continuous pressure on pelvic veins. Age is also important. Hemorrhoids are rarely seen in people under 30, but their incidence rises steadily as supporting tissues weaken with age. Any condition that causes chronically elevated intra-abdominal pressure, like a persistent cough, can also predispose someone. And finally, conditions such as portal hypertension increase venous pressure and make hemorrhoids more likely. Understanding these risk factors is crucial, because they guide both prevention and management strategies. Next, let's classify hemorrhoids according to the degree of prolapse. First-degree hemorrhoids, these are swollen cushions that do not prolapse outside the anal canal. Second-degree hemorrhoids, these prolapse during straining, but then spontaneously reduce back inside on their own. Third-degree hemorrhoids, these also prolapse, but they do not go back spontaneously. Instead, they can be pushed back manually by the patient. Fourth-degree hemorrhoids, these are the most advanced form. They remain prolapsed and cannot be reduced, often requiring surgical management. This classification is important because it not only describes the progression of disease, but also guides the choice of treatment. Most of the time, hemorrhoids can be asymptomatic, discovered only during examination. But when symptoms do appear, the commonest complaints include a lump at the anus, especially with external hemorrhoids. Painless rectal bleeding, classically described as fresh red blood splashing into the commode bowl. Anal itching or irritation, which can be very distressing for patients. To confirm the diagnosis, we use proctoscopy, which allows direct visualization of the hemorrhoids inside the anal canal. This step is important not only for diagnosis, but also to exclude other possible causes of rectal bleeding. Management of hemorrhoids depends on the severity of the disease and the patient's symptoms. For milder cases, conservative treatment is often effective. Topical steroid creams can help reduce inflammation. Lignocaine gel provides local pain relief. When conservative measures are not enough, we move to office-based procedures. Rubber band ligation, where a small elastic band is placed at the base of the hemorrhoid, cutting off blood supply until it shrinks. Sclerotherapy, often using phenol in oil, which causes fibrosis and shrinkage of the hemorrhoid. Infrared coagulation and diathermy, both of which use heat or energy to destroy the abnormal tissue. For severe or recurrent hemorrhoids, especially fourth-degree cases, the definitive treatment is hemorrhoidectomy, surgical removal of the hemorrhoidal tissue. Although more invasive, it provides long-term relief in advanced cases. Finally, let's talk about prevention. The best way to avoid hemorrhoids, or to reduce recurrence after treatment, is to maintain healthy bowel habits. A high-fiber diet keeps stools soft and reduces straining. Adequate fluid intake helps the digestive system run smoothly. And sitz baths, simply sitting in warm water, can provide comfort, improve circulation, and reduce symptoms in those prone to hemorrhoids. Prevention is all about simple lifestyle choices that protect long-term health. End of today's video on hemorrhoids, from anatomy and pathology, to risk factors, diagnosis, management, and prevention. If you found this video useful, please like, share, and subscribe to Medics in Minutes for more quick and clear medical insights. Thank you for watching, and see you in the next video.